Hello, everyone. Good afternoon. I hope all of you are doing well. Thank you so much for joining us today. We have a very interesting session planned, and we promise to make the next 45 minutes thoroughly engaging for all of you. Let me quickly introduce myself. I'm Pooja Sharma. I'm an associate consultant at Viscadia based out of our Boston office, and I will be the moderator for the event today. Before we get started, let's get some of the housekeeping items out of the way. To run a quick audio check, we'll be sharing a poll with you that you can access using the bottom right corner of your screen. Please select the yes option if you can hear me clearly. And while you do that, some other things to keep in mind are that the audio for the attendees will be muted during the course of the event. We will be recording the webinar and we'll share it with you after the event. And we will have time for Q&A towards the end of the webinar. To keep it interactive, please feel free to post your questions as and when they come using the question icon at the bottom right corner of your screen. I will have access to those and I'll ensure that our panelists address them. Okay. With that, let me introduce our two panel members for this webinar. The first member on the panel today is our founder and CEO, Satish Kotta. Satish is a career-long forecaster, and prior to founding Viscadia, he spent the first 14 years of his career working cross-functionally with commercial, finance, and business development teams. Satish is passionate about Viscadia's mission to empower the life sciences industry with clarity and confidence through forecasting. And he's based out of our Washington, D.C. office. The second member on the panel today is our principal, Anindya Roy. Anindya has 15 plus years of experience in management consulting for life sciences. And prior to Viscadia, he specialized in Salesforce sizing and structuring promotional effectiveness at ZS. Anindya is very keen on understanding a patient's journey and the treatment decision frameworks at play across the different therapy areas and how that translates into the product story. He's based out of our Boston office. And to start us off, Satish would like to give us a brief overview of Viscadia. Over to you, Satish.
Thank you, Pooja. Just to give you a brief overview about who we are and what we do, we're a specialized firm that's exclusively focused on forecasting within the life science industry. We have offices both in Boston and in Washington, D.C., here in the United States, as well as an office in New Delhi out of India. The three areas that we feel really drive the forecasts is first, models and platforms. So here at Viscadia, we do a lot of design and build, both in terms of pipeline as well as on-market assets. As Pooja has mentioned, we also do quite a bit of work on the business development front when it comes to models and platforms. The second pillar of forecasting is really market research. The type of market research specifically that drives the forecast, such as segmentation, demand studies, and buying process research. And then finally, the third pillar is really ongoing support in the framework of cycle support. So all of our clients have some shade of either monthly needs, quarterly needs, and definitely annual needs where they revisit their forecasts and they need some type of external partner to help them both strategically as well as tactically. And again, this runs the whole gambit of on-market pipeline as well as commercial development assets. So today we're here to talk about cervical cancer. And I think the timing couldn't be better with respect to January is globally recognized as our annual awareness month for cervical cancer. The challenge, as you can see, is there's almost 14,000 cases that were presented in 2023. This is a mixture of both actuals as well as projections. And if you really think through these numbers, think what's not captured in these numbers. Think about how many families and lives that this has affected just in 2023 and how many people have been affected over the last few decades and will continue to be affected. And that's really the first step that we take here at Viscadia is always really understand what the patient is going through when being diagnosed, what they're doing, what they're feeling when they're being treated as well. So one of the things before we really get into the forecasts is we really want to discuss through the prism of a particular patient, what a woman really goes through once she is diagnosed and begins treatment. So the first challenge that she faces is really physiological. As you can imagine, with all oncology diagnosis and treatments, you have a severe set of symptoms, and the chemotherapy really takes its toll on the body. And cervical cancer is not immune to any of these classical and really painful symptoms. Then you have the psychological component, right? So if you really think about beyond the physiological challenges that a woman would face, you really have the psychological component of, how am I going to deal with this? This is a journey. I'm not going to get through this quickly. Through the power of my family, through the power of faith, and through the power of medicine, I will get through this. However, there is a psychological component that we should all be mindful of. And then there's the emotional component, this ongoing component that the realities start to set in, that there's long-term effects, even if you look at the positive outcomes. And in terms of cervical cancer in particular, you have this real particular challenge that once you go through the radiation therapy, you're most likely not going to be able to bear children. And this takes obviously a really huge emotional toll, even as you're facing the other challenges. And as if this isn't enough, we have the realities here in the United States of the financial component, that while you're navigating through this, the best case scenario is that you have insurance, but there's a burden that comes along with the insurance that's covered, not to mention, suppose you don't have the best case scenario and you have insurance that really changes over time, or God forbid, you're actually gapped. So as we go through the forecasting elements, as we go through the therapies and the treatment paradigm, through an analytical prism, we should be mindful that at the epicenter, we're really trying to be mindful of the actual patient, what she's going through, and by extension, her families. So with that, I'm going to pass it off to Anandya, and we can start talking about the actual patient journey.
Sounds good. Thanks, Satish. Just quick check. Satish, am I audible? Can you validate?
Yes, Anandya, thank you.
Okay, sounds good. Yep. Thanks, Satish, for for setting that up. And like with most solid tumors or cancer in general, I think it all starts with the patient's journey, right? And like what we see here on the screen is basically an actual journal from a patient's journey. This is for a patient who was, diagnosed and treated for stage 4 cervical cancer. So a couple of things stick out here, right? I mean, it is a long and arduous journey, sometimes several months to years. And this includes procedures and regimens that take a heavy toll at multiple levels, like Satish was saying. So I think what becomes very important is for us to understand the basics of that journey, right? And that is what basically forms the foundation of the diagnosis, which will then be followed by the treatment. So on the right of the screen, what we have here is like a schematic description of the diagnosis and treatment journey, right? Uh, Especially in the United States, there is access to periodic screening, and I think that is where this all starts. Women in this age bracket um, are kind of advised to undergo regular screening, and that includes a few tests, to be specific, right? There's this pap smear test, which since its inception in the sometime in the later half of the last century has been kind of a paradigm shift in terms of identification of the early signs of cervical cancer. And then there are liquid based cytology or HPV test, and we'll talk about HPV quite a bit because it is one of the big determinants of cervical cancer. So the biopsy that is kind of done for cervical cancer, it is called colposcopy. Basically, a medical procedure which closely examines the cervix, the vagina, and the vulva for signs of the disease, right? Particularly with the goal to identify abnormal cell changes that lead to cancer, correct? And once this biopsy or this test is run, there are, you know, three possible outcomes, or the way to think about is grades of outcomes. So, and we talk about it in terms of the CIN score, right? CIN stands for cervical intraepithelial neoplasia. This basically describes the magnitude or the quantity of the abnormality or change that we see on the on the surface of the cervix. So CIN1 is basically the lowest grade. It is mild changes only, and this kind of the advice for this is constant screening and monitoring, but no treatment per se. CIN 2 and 3, this is like relatively higher degree of abnormality, but then this is still considered precancerous. There is a lesion, but that is precancerous lesion. And this is where some preliminary management comes into the picture, right? CKC, I think it is called, CKC stands for cold knife conization. There is LEAP, which is used quite a bit. LEAP is basically like there's an electrical wire that basically is used to carry out the excision. So I think it is called loop electrosurgical excision procedure. That is what LEAP stands for. And then there is cryotherapy, which is basically treatment of the impacted cells with very low temperature exposure to kind of manage their spread. Okay, but the last part here is basically what constitutes the cancer. So if we see that the extent of abnormality in the cells is past a certain level, that is where it is classified as cancer. And then the diagnosis procedure basically includes the imaging assessment, which is the MRI, sometimes followed by the tomographies, right? Both CT, PET, and whatever is available to kind of test the spread of the disease, right? Because now that we know that the disease is there, we also need to understand what stage, right? Which basically is what the diagnosis eventually translates to, right? What is the stage of the disease? And like with most solid tumors, and there is a staging mechanism that is followed here. And anything which is starting 1A1 through 1B1 is considered early stage of the disease, right? This is still, and basically the staging is in terms of how far the disease has progressed, whether it is only in the localized cells or it has spread outside of the localized cells but has not gotten to the lymph nodes, or it has gotten to the lymph nodes but how many, and then whether it has progressed outside of the actual site of the tumor. So that is how typically these staging mechanisms or these staging conventions are followed. So we have like early disease, we have locally advanced disease, where it is considered that the disease has advanced, but it has not gone outside uh, of the localized site, right? And then we have metastatic, where the disease has unfortunately gone on to other organs. And again, depending on whether those are adjacent organs or distant organs, I mean, metastatic disease is characterized differently in different scenarios. But this is roughly the stages of the diagnosis and the disease that a woman can expect. Okay. So now that we have talked about this, I think the next thing to understand is, uh, where do we see most of the incidents, or where do we see, or which stage do we see most of the women who are undergoing treatment for cervical cancer present, right? So like if we see in this chart, and this is mostly US data for 2023, we see that about 50%, which is half of the patients under treatment, are in the later stages of the disease, which is stage 3, 4A and stage 4B. So this is locally advanced and metastatic. And then there are the other half, which are in the early stages. But now let's also try to understand what are the uh, treatment mechanisms, or what are the treatment modalities that are typically used to treat these patients, right? So, a couple of trends to observe here, right? Like as you see, or as we come down, top down, you will see that the proportion represented by green, and green here is basically surgery, progressively comes down. Why is this the case? Because as the disease progresses, as its spread now goes on to other areas outside of the area where it originated, uh, there is limited scope or benefit for resection, right? So in the early stages, we see a lot of patients being treated with surgery, but that comes down. Okay, there is a little more of radiotherapy which is used in these stages, which is the middle stages, radiotherapy and surgery plus other systemic therapy. But as we come or as we advance to the higher stages, we see more of the systemic therapies being used. This is where targeted medicine comes into picture. This is where the immuno-oncologies that we talk about in most solid tumors come into picture, and they basically, their usage is the highest in locally advanced and metastatic disease. So these are some of the directional trends in terms of treatment modalities. I think the standard of care for early stage disease management continues to be, platinum based chemotherapy. That has primarily been, uh, the weapon that doctors have used traditionally for early stage cancer. So is the case with cervical, and one of the biggest drugs around today, pembrolizumab or Keytruda, in combination with chemo and with or without Avastin. And we'll talk about that in a bit. Avastin is an angiogenesis inhibitor that was approved in, I think, late 2021 for first line patients with PDL1 positive status. So PDL1 is a biomarker expression where, if your CPS or the progression score is greater than 1, the patient is considered PDL1 positive. So for the PDL1 positive patients, Keytruda in combination with Bev and chemo was approved. And now, as of like late 2023, that accounts for almost half of the first line PDL1 positive patients as well as the second line ones, right? And then the different platinum doublets, which is paclitaxel based or irinotecan based, with or without Bev, is used as the standard of care for PDL1 negative patients. Okay, and there are some recently approved systemic therapies also, which we are going to talk about in more detail in the subsequent sections. They are being increasingly used in later line patients across different patient cohorts. Okay, so what typically when you try to understand uh, treatment landscape or progression of treatment of a patient, we talk in terms of patient flow, and this basically picks up from how the patient is diagnosed to how the disease progresses, and hence the treatment follows, right? So what we talk about first is the first line systemic therapy, and here we are just focusing on the metastatic disease, which is pretty much stage 4A, stage 4B. So once that diagnosis has come in, there is a segment of patients who are giving like systemic treatment alone, and then there are some who have surgery or surgery in combination with radiotherapy. So again, starting and testing for biomarkers is a big thing in solid tumors, and I think we can safely say that in most tumors, more than three-fourths of the patients are tested for the primary biomarkers, PDL1 being one of them. HPV is a big factor here for cervical cancer, so that testing rate is also going to be very high. And most of those patients are tested ahead of first line only, right? So for the PDL1 positive patients, we see a lot of Pembro being used, like we said, in combination with Bev, sometimes without it, and with the platinum doublets, right? Primarily carboplatin or cisplatin. Okay, but all those patients who got systemic treatment in first line, of them, some of them progress, right? Or the patients who got systemic treatment along with surgery, they also progress, right? And now in the second line, we have a similar uh, spread, right? There are some patients who are getting just systemic. There are some who, at this stage start, going untreated because of tolerability issues or the overall condition and performance score of the patient. Some patients we lose to the disease at this point, and some patients have complete remission. So across the biomarker types, we look at what is the spread of these outcomes or treatment modalities for patient. And here also in second line, and we are just looking at like the the top three regimens that are used for treatment. This is based off of 2023 data. So PDL1 positive patients, like we talked about, again, Keytruda is the primary treatment mechanism now, either as a monotherapy, and monotherapy used to be used more before, but since the approval of the combo therapy with platinum and bev, that has now kind of been pushed more to second line. And for PDL1 negative patients also, I think this is where some of the newer regimens are coming in. Tisotumab vedotin, or Tivdak, is an ADC, which has kind of seen quite a bit of adoption in the last few years since its approval in, again, late 2021. Okay. On to third line, and we are talking about third line here because for cervical cancer, the overall survival kind of affords the runway for patients to get a third line of treatment. There are tumors where the OS is not that high, and we probably have very few patients going on to third line treatment. But here in cervical cancer, we do quite a bit, right? And we'll talk about a few other treatment dynamics which kind of define this. But third line, again, pretty similar, right? By this time, you have already meaning the patient has already had experience on the IOs. So it's more like TV, which is used a lot for the PDL1 negative patients. And for the PDL1 positive, still Pembro is being used in multiple combinations, right? That is the beauty of that IO, that it can be used in different combinations, switching either the chemo backbone or what it is combined with to gain more of a treatment runway. But this kind of a treatment pathway is what lays the foundation for when we start building out a patient flow model, right? We need to understand what are the specific dynamics that are in play, and how is the patient progressing through the different lines of treatment. In each line, what are the available treatment modalities, and roughly what is the progression on each of them, and what happens when the patient has progressed through all the available lines of treatment, right? This is what constitutes the foundation of that patient flow modeling. Okay, we talked about the different treatment modalities, so I think it makes sense to go in a little bit of detail about what the classes are, right? Because that is how you think about it. What are the drug classes available for treatment across the different lines, across biomarker types? And in solid tumors more than others, but in cancer in general, treatment decisions are made primarily on a few factors. One is biomarker expression, right? What is the kind of protein or oncogene that finds expression on the particular cancer cell that we are talking about? And what are the ways to target it? That is one. The other thing is prior treatment history. Like a lot of these new agents which are now being approved, if we look at what they are indicated for, it will read blank is approved for patients with recurrent metastatic cervical cancer with blank, which is basically something like 2 lines of prior systemic therapy or post progression from chemotherapy. So prior treatment history is a big determinant of choice. So in terms of drug classes, chemotherapy has been the traditional modality that is used. So here, it all started with kind of cisplatin monotherapy, then it came to the non-cisplatin agents. So although these chemos, they deliver on the efficacy side, which is improved overall survival, which is OS or ORR, but they have like a lot of safety and tolerability issues, right? So then came the next generation, which is immunotherapy. Here we are talking about specific biomarkers or oncoproteins which are being targeted. And whenever we are talking about immunotherapy, I mean, some of the biggest IOs around today, which is Keytruda or Opdivo, they are all PD-1 inhibitors, right? Recently we have, in terms of, when I say recently, in terms of cervical cancer, we have this Regeneron drug, Libtayo, cemiplimab, that is also a PD-1 inhibitor. We also have, the PDL1 inhibitors, which is Atizo, avelumab, durvalumab, all of them. And we have this new class now, I mean, not new anymore, but CTLA4, right? And zalifrelimab is kind of a big and promising pipeline agent that is considered key to cervical cancer pipelines across the board. So that's the second thing. And then the third thing, like I was saying, right, the chemo helps with um, synergizing a lot of what the immunotherapy does. So combination therapy, and that is pretty much the case with most other tumors as well, but very much so in cervical cancer, that combination therapies are being looked at very actively. And I think the approval of Keytruda and the positive data that it has yielded in uh, first line treatment has kind of put a lot of focus on this, but different combinations are being used. The next set of drugs are all some specific mechanisms of actions, such as angiogenesis inhibitors, right? So bev is one product which is used widely in a lot of these combinations, and that is because what happens is, beyond a point, once the tumor grows, uh, it it induces some sort of hypoxia, which basically means that the tumor microenvironment has grown so big that the blood flow is constricted, and that impedes our ability to deliver the drug there. So that is where the angiogenesis pathway inhibitors come into play, and that is why bev is used in combination with a lot of the other drugs to facilitate the delivery of the actual drug to the tumor site. And hence, that is where the outcomes come from. We have EGFR inhibitors, cetuximab. I think this is used quite a bit in. We see the use of cetuximab being much higher in geographies such as Japan. We talked about TV, right? TV, it is an ADC, tisotumab vedotin. It was approved, I think, late 2021, September of 2021, and has seen good uptake since. Then we have a few other classes as well. So overall, this kind of maps the landscape for the treatment modalities for cervical cancer, and even most of the pipeline activity can also be mapped to these drug classes. Okay, so we have talked about the diagnosis and the progression of the disease, how it is treated, but let's also kind of focus a little bit on what the risk factors are. Some of these things that you would see here uh, is what you have seen across other solid tumors as well, right? For example, tobacco use. I think uh, in squamous cell cancers of the head and neck, tobacco use is one of the biggest risk factors that we have known. Immunocompromised status for a long time again leads to the likelihood of several cancers. But when it comes to cervical cancer, I think exposure to the human papilloma virus, or HPV as it is widely known, is considered the biggest risk factor per se. And then it has some adjacencies also, right? Like exposure to multiple sexual partners, or women in low and middle income countries where they have multiple childbirths, and we are talking about in excess of 3 children. They have demonstrated higher likelihoods to be exposed to cervical cancer risk than otherwise. So there are several factors, but yeah, human papilloma virus, or HPV, is kind of the biggest determinant, and we'll talk about that in a little more detail in a bit. But I think it suffices to say that not all HPV infections cause cervical cancer, but 9 out of every 10 or more than that instances of cervical cancer can be traced back to an HPV infection. So that kind of underscores how big of a risk factor HPV is. Okay, so let's also look a little bit into what the screening and vaccination for HPV, what these programs look like, and what is their real impact on the incidence of cervical cancer, right? So in terms of histology, I think there are primarily two oncoproteins, which is E6 and E7, and these are the main biomarkers of cervical cancer cells, right? And these are the ones which are driving progression. So obviously, like from a mechanism of action standpoint, the repression of these E6 and E7 signaling pathways, or their molecular mechanistics, make for effective treatment mechanisms for cervical cancer. Okay, so now let's look at Let's zoom out a little bit from just the US, and I'll tell you in a little bit why, and look at the global burden of it, right? Like if you can see here, like the graphic up top is age standardized incidence, and the graphic below is age standardized mortality, right? So this is US, which is a much lighter shade for both the blue and the red. And if you look at sub-Saharan Africa, or more like the lower income regions of Latin America, they are the higher shades of or they are the darker shades in both these colors. India, some of these nations here, the densely populated nations in Southeast Asia, they have much higher incidence and standardized in incidence and mortality. Why is that the case? I think this can be mapped back to what we are saying as um, you know HPV screening and vaccination measures, which overall control the incidence of cervical cancer in the longer term, right? So if we look at just the low to middle income countries, they account for easily more than half of the global burden of it. And if you start correlating here, these inequities are also reflected squarely in screening and vaccination rates. Like I think in the low to middle income countries, only 30% of the women in this age group have embraced vaccination, whereas in high income countries it is 85%. Likewise, the screening adoption is all or penetration is also much less in the low to middle income countries. So I think it is very clear from this that the incidence of cervical cancer is correlated very directly to uh, vaccination rates and access to screening. Okay, and there are also like studies which have been conducted in different global regions to see how cervical cancer incidence is impacted by these, right? And there are some these are called some micro simulation models. There are two typical models. One is it's called the Harvard model, the other one is the cervix one model. But they have been run in different regions to see basically two things: uh, what vaccination rate and uh, access to screening would basically bring down the incidence to levels where cervical cancer ceases to be a public health threat anymore. And the threshold for that is considered to be 4 women per 100,000 women years, right? And if you see under different scenarios, a combination of vaccination as well as screening has gone a long way in bringing down the incidence rate over the years. I think the incidence rates have come down quite a bit in the later half of last century, but have flattened ever since. But it's a constant effort on part of global health initiatives to kind of drive towards this end goal. Okay, we'll talk a little bit about the HPV vaccines because that's what we know are one of our biggest weapons in curbing incidence for cervical cancer. So I think there are three classes of vaccines that are approved. It all started with what used to be the bivalent HPV vaccine or the quadrivalent one, but now the one that is predominantly used for the last 7-8 years, it's the 9-valent HPV vaccine or Gardasil 9. Okay, and since 2016, this is pretty much the only vaccine which is distributed in the US. In some of the other ex-US regions, the other vaccines are still distributed. But I think there is significant data to suggest that these are very effective and have contributed to drops in incidence rate, and their protection also lasts at least more than 12 years. So that is roughly the spread of the longitudinal studies where the trackings have been run, and they have been established to be fairly effective. Okay, so for most other cancers, as is the case with cervical cancer, it all starts with understanding what the patient opportunity is, right? Like if you are responsible for kind of assessing the potential of a drug that is either approved or in the pipeline for cervical cancer, these are the basic elements that you will start with, right? And understanding the patient opportunity is one of them. Where do you source the epidemiology from? What are the key considerations there? What is your target addressable opportunity? Biomarkers, all these things, right? Then you try to understand what your product profile is. How does it compare against the standard of care in terms of key attributes? What are the treatment guidelines? Like in cervical cancer, it is one space where it has been demonstrated that the practitioners or the oncologists follow the NCCN guidelines much more fastidiously than they do in some other some other cancers. What the key competitors are, we talked about all the classes and the combo therapies that are under development. I think understanding physician preferences is very key, right? Like we know in cervical cancer, OS is the primary driver of treatment choice. So how you pose the questions in your demand research and whether that brings out the specific differentiation that sets your product apart from competition, that is becoming very key. And understanding the physician attitudes and responses at the particular patient subgroup level, all of these things are what make like a good demand assessment design in areas such as cervical cancer. We talked about market events. I think HPV and its impact on long-term incidence is key, something that we should be factoring into. Launch dynamics, right? We'll see that a lot of these products are all getting accelerated approvals, which means they are going to get a lot of patients around launch, bolus patients. What are the subtypes of these patients? Stuff like that. Distribution becomes important because this determines how you get the data and what you can do with the actual performance data. This is real world data. And factors such as understanding the duration of therapy, because this has its specific nuances when it comes to cervical cancer. There are patients, because of the toxicity profiles of the cervical cancer drugs, they go on treatment holidays. So how do you account for them? Stuff like that. So I think these are all the elements which kind of contribute to a good forecast when it comes to a cervical cancer asset. And the building blocks for that are pretty much what we talked about, right? You should know what your epidemiology looks like and how you work it with. Patient flow modeling is very key because this is where the nuances come into play. Demand research, a lot of literature review, because you need to bring in a lot of assumptions to the forecast which are not readily available. So to do that, and the core message here is all the available sources of information should be leveraged, and they should be reconciled in a way that they make for a very comprehensive and clear story. Okay, so I think in summary, the key takeaways are there is a huge burden of this disease still to this day, and there are a lot of inequities. We just talk about US, but globally, this is a much bigger burden. There are unmet needs still, like in terms of efficacy. I think we have made good progress in the last few years, but toxicity and tolerability still continue to be still continue to be unmet needs, and there are several underserved pockets of patients as well. There are new treatment modalities which are addressing them, but overall, this disease is kind of preventable and treatable, right? So, we started off going through the, multimodal aspects of the burden of the disease, but, bringing it all together, and this is the same patient story that we looked at there. There is life after cervical cancer. A lot of progress has been made through science in the last few years, but there is still a few, like we are some ways away from completely getting over this disease. But yeah, I mean, if we understand the journey of the disease, I think that makes things easier. Okay, so with that, I will conclude this section and I'll pass it over to Pooja for any Q&A.
All right. Thanks, Anindya. We can now take up some of the questions that we've received from our attendees. So the first question that we got is, with the vaccine hesitancy coming out of the pandemic, just wondering if and how you think this has impacted forecasts for cervical cancer drugs coming to market in the next few years.
Sure, I can take that. So this is a very challenging and timely question. As forecasting specialists in the life science industry, we work really hard to stay clear of the politics and the polarization that can potentially cloud the truth here. But we also have to work equally hard to ensure that we're not ignoring the realities here as we continue down the modeling pathway. So we feel that a good way to quantify the impact vaccine hesitancy on incidence is through the use of microsimulation models, as Anandya mentioned. The two major models that are being widely used is the Harvard and the Policy One Cervix models. These models analyze the scenarios that come out of the combination of prophylactic HPV vaccination as well as the cervical cancer screening. So I think working these two in harmony is really a good source of truth. And also, let's be mindful of the big picture here. As challenging as the current environment may be as we were coming out of the pandemic, there is some good news here. At a very high level, the US is on track to actually eliminate cervical cancer as a public health problem in the next 2 to 3 decades. The time to elimination is driven, by factors such as vaccine coverage and proactive screening. So considering the time between acquiring an HPV infection and the development of cervical cancer, there is a lag effect that must be accounted for, modeled, and measured. So we must consider some of the launch scenarios which simulate for incidence reduction in the forecast horizon for any of the drugs that we're considering. And these should be consistent with the trends in incidence that we've seen over the last decade, while being mindful that the decade has multiple stories at play here, where it sharply began with reduction, but then has plateaued in the last few years.
All right, thanks for that, Satish. The next question that we received is, there has been a lot of interest in ADCs in various therapeutic categories, and at least one recently approved ADC therapy in cervical cancer. Is there anything special about developing forecasts for ADCs in cervical cancer and other therapeutic areas?
Okay, so I'll take that, Pooja. So yes, there is one ADC that is approved for the treatment of cervical cancer. I think we are talking about Tivdak. Let's be also mindful that there is a second ADC, Elahere, which is approved primarily for ovarian and fallopian cancer. I think it is approved for what is the folate receptor alpha positive patient pool, but they are also used in peritoneal cancer, which is basically the early stages of cervical cancer, right? So the thing with ADCs are, because of their mechanisms of action, they are delivering outcomes for very specific but underserved patient subtypes, right? Either by prior treatment history or by biomarker expression, like in the case of Ella here, like folate receptor alpha positive is a very specific patient subgroup. So they are essentially expanding the target population for systemic treatments in a way, right? So when it comes to like modeling or forecasting, this has implications on epidemiology. This has implications on patient segmentation. So those things become very key, right? That is, I think, one thing that I can think of. The second thing is, the target patient subtypes are based on prior treatment history, like we said, and most of them are later line treatments. So understanding of the overall longitudinal journey of a patient's treatment becomes extremely important. This is why I think in some of the ADCs more than others, the construct of the patient flow is what becomes supremely important, correct? If you look at Tivdak or Ella here for that matter, most of these ADCs, they are getting accelerated approval, right? Which means there are certain launch dynamics such as bolus patients, which are very predominant here. You need to understand what are the kind of patients you will get pretty much at launch to be able to get your supply forecasts and like the commercial forecast right. So I think these are some of the primary things we should think about. Yeah, the other thing is like at least for the cervical cancer ADC we're talking about, these typically have some toxicity profiles associated with it, right? So to manage them, what the doctors do is cycle across other systemic treatments. So when we see in the patient data that a patient has been on the ADC but then discontinued for a while and comes back again, we should look at that as a treatment break rather than more like progression on treatment. So these are elements which I think are typical of most ADCs, and we see them in cervical cancer as well. So we should be mindful about these things while forecasting or modeling for an ADC in solid tumors.
Thanks, Anindya. The next question is, how has the approval of Pembro for 1L PDL1 patients impacted the treatment sequencing in cervical cancer?
Okay, I'll take that one too. Okay, so yes, Pembro or Keytruda, it was approved for cervical cancer treatment. I think in the last quarter of 2021, right? And this is with chemo, with or without Avastin. I think that is what the label for Pembro is, and like we have to understand that Pembro is a immune checkpoint inhibitor, right? It's a CPI, and like Avastin, I think we talked about briefly in the discussion, it is an angiogenesis inhibitor. So these two in combination make for a good early line treatment. So that's the important thing to note here. And since it was approved, it has kind of established a new standard of care for first line treatment, especially for PDL1 patients. A majority of the PDL1 positive patients in first and second line are now being treated with Pembro. So, so there are implications on both sides, right? For Pembro, okay, uh, a lot of the patients who were otherwise coming to this drug in second line are now coming under first line. So Pembro has much higher duration of therapy now in the overall patient population than it had before. Let's also think about the impact on the other therapies. Like a lot of the drugs are labeled for patients with disease progression after an IO. Let's say that is how their labels are, right? So with Pembro moving up the treatment ladder, some of these drugs have also seen usage now sooner than they would otherwise have been used. So that is also a dynamic which has an impact on their duration of therapies as well. And the other thing with Pembro, or primarily with the IOs in this space, is they afford the opportunity for a lot of combination regimens too. So that has given the oncologists, the option to kind of either cycle the chemo background or try some other combination alongside the primary IO, which is Pembro here, to extend the overall survival of the patients. So yeah, I mean, like with most other solid tumors, Pembro has demonstrated good data in cervical cancer too, and that has impacted the overall treatment landscape in very manifest ways.
Thanks, Anindya. The next question is, why is it that the claims data almost always points to a lower duration on therapy for actual patients than what is reported in the trials?
Okay. I see what this is getting. So yeah, so this is something we talked about in the main section, right? Like what's happening here is a lot of these drugs, they have some toxicity associated with their usage, right? Sometimes there is a there's a certain dosage threshold above which the toxicity kicks in. Sometimes it's otherwise. For example, the ADC in cervical cancer treatment has come with a black box warning also. So what this means is oncologists are cycling the available systemic treatments available. So when you look at the claims data, this has to be kind of recognized and modeled for appropriately, right? If you see a patient has been on therapy for, I'm just making this up, okay, let's say 4.5 weeks, 4.5 months, but then there is a break. Whether that break is a treatment holiday or whether it's discontinuation, that is where I think the modeling sensitivities come in. But yeah, directionally, when we are looking at the real world data, depending on its capture rate and qualities with coding, we do see that duration of therapy is typically lower there than what it is seen in actual patient usage.
All right. Those were all the questions that we received. I would like to thank everyone again for joining us today. And if you have any further questions or would like to continue the discussion, please don't hesitate to reach out to us. And stay tuned for more exciting webinars and events focused on forecasting within the life sciences industry. And have a great rest of your day. Thank you, everyone. Bye-bye.